Hello, everybody. We'll be discussing the second part of opioid analgesics in this session. So, in the last session, we have completed the pharmacology of morphine. Today, we shall be discussing regarding the other opioid agonists. We also will be discussing about mixed action opioids and finally the opioid antagonist. So, this is a classification which I had shown you in the previous class. So, we already discussed morphine. Today, we shall be discussing about codeine and synthetic opioids like pethidine, fentanyl, methadone, and tramadol. We shall not be looking into the synthetic opioids like heroin because these have been covered or will be covered in drugs of abuse. Now, codeine is a naturally occurring opioid and it is a partial agonist at mu opioid receptor. So, you already know the definition of partial agonist. That is something that has the same affinity at the receptor, just like the full agonist, but will produce submaximal effect as compared to the full agonist. So, when you compare codeine with morphine, it has got good oral absorption, and codeine is one drug which gets converted in the body to morphine. Now, when you compare codeine with morphine, the most important thing to see with codeine is that it is less potent and less efficacious analgesic. It is rather more selective cuff suppressant. So you have seen a lot of actions of mu receptors, and one of the actions was cuff suppression. This codeine is actually more selective on that particular action, that is cuff suppression, and it produces cuff suppression even at sub-analgesic doses. It also has less addiction liability as compared to morphine, and there is no reports of tolerance developing to codeine. Okay, so because it is more selective cuff suppressant and not efficacious analgesic. Its main use is as a cough suppressant, and it is mainly used as oral tablets and syrups for this purpose. It is also used as an anti-diarrheal drug, which you already have seen while we discussed about the drugs for diarrhea. Now, its use as an anti-diarrheal is actually an interesting find, which actually was which came out as an outcome of its ADR. So when people were using cough suppressants, the most common adverse reaction that they developed was constipation, and this led to the use of codeine as an anti-diarrheal drug. So this is one example of an event where the adverse drug reaction actually became the clue to its a second therapeutic use. Next, we have folcodeine and dextromethorphan. These are the analogs of codeine, which are having very fewer side effects as compared to codeine. So you will see more of dextromethorphan in the cough syrups nowadays. If you have a sample of cough suppressant in your house or in your hostel, you can always see and you'll always find this dextromethorphan in the ingredients list. So this is more common now because of its very few side effects as compared to codeine. Next is pethidine, otherwise called as meperidine in some countries. This is synthetic opioid and it's an agonist at mu opioid receptor. When we compare with morphine, we see that it is less potent but equally efficacious analgesic than morphine. You already have quoted this example very in the very beginning when we were discussing about potency and efficacy. So it is less potent means that you'll require approximately 100 milligram of pethidine to produce the same analgesic effect that is produced by 10 milligram of morphine. That is, it is less potent. But 100 milligram of pethidine or the 10 milligram of morphine will produce a certain amount of analgesia, and that is equal. Means the maximum effect produced by both these drugs is same. That is, the efficacy is same, but you will require more amount of pethidine as compared to morphine to produce a certain level of analgesia. That is why it's called as less potent but equally efficacious. It is having a better oral absorption than morphine, and it's also given by IM injection when the onset of action is more rapid, but duration is shorter. That is only lasts only for 2 to 3 hours after an IM injection. This pethidine also has got some local anesthetic action, and that is why it can be used for corneal anesthesia. It is not a good cough suppressant. Now, when you see pethidine, you will find more of tachycardia instead of bradycardia. You have seen that bradycardia was present in the case of morphine, but here it is tachycardia mainly because of it and because of its antimuscarinic action or the atropinic or the anticholinergic action. It also causes less histamine release as compared to morphine, and therefore it can be used as an analgesic in asthmatics with pain. The spasmodic action on smooth muscles is less compared to that of morphine. So you will see less of meiosis, less of constipation, less of urinary retention, and less of biliary spasm with pethidine as compared to morphine. Now, this comparison with morphine is very important and is often asked in the questions. And please note this, 8 points as the differences of pethidine from morphine. Now, the ADRs, you'll see that it is very similar to morphine, except the differences that I have mentioned earlier. That is, instead of bradycardia, you see more of tachycardia and all. And the other things that we mentioned earlier, the ADRs coming out of those consequences are not there. But otherwise, the ADRs of pethidine are very similar to that of morphine. Additionally, some of the pethidine can also produce some of the other adverse reactions, that is atropinic side effects. You know that it has got atropinic actions also. The people taking pethidine may develop dry mouth, blurred vision because of mydriasis and tachycardia. These are all anticholinergic or atropinic or antimuscarinic side effects. So this is most important side effect that you have to remember additionally in the case of pethidine. And the overdose of pethidine can produce excitatory effects like tremors, hyperreflexia, delirium, myoclonus, and convulsions. And this is attributed mainly to the accumulation of a metabolite, norpethidine, which is produced from pethidine. And this particular metabolite has got excitant actions, and that is why you end up with tremors, mydriasis, and other excitatory effects. The tolerance and dependence develop slowly with pethidine because of its shorter duration of action. So always remember that any drug which is having a shorter duration of action, that the tolerance and dependence usually develop slowly with that kind of drug. This is a very important point to note, which will help you in the understanding the further slides also. So this again, the ADR of pethidine, the one of the important ADRs to note is mainly the atropinic effects and the excitatory effects because of the presence of norpethidine. Now, the use, before we go to the use of pethidine, we'll see that the non-selective MAO inhibitors, which are used mainly as antidepressants, they decrease the metabolism of pethidine and increase the toxicity. So you have to be very careful when you are giving pethidine to people who are on non-selective MAO inhibitors. You are yet to learn those drugs, and when you learn that, one of the important interactions of these non-selective MAO inhibitors is with pethidine. Then pethidine should not be given to patients who are taking SSRIs, selective serotonin reuptake inhibitors, which are another class of antidepressant drugs, which you are yet to learn. If you give pethidine in such patients, that can lead to serotonin syndrome by enhancing the serotonin release. So pethidine is contraindicated in individuals or people on depression who are taking MAO, non-selective MAO inhibitors or are taking SSRIs. Now, the use of pethidine, it is mainly used as analgesic for visceral pain, just like morphine. But we know that it is less potent but equally efficacious as that of morphine. It is also used as pre-anesthetic medication, just like morphine was used. It's also used to control shivering during recovery from the anesthesia or following IV infusion. This is one additional use of pethidine. Then it is preferred opioid analgesic during labor because neonatal respiratory depression with it is less marked. So when we were discussing about morphine, we had mentioned that morphine should be contraindicated during labor because it can cause neonatal respiratory depression. And if that happens, we have to inject naloxone through the umbilicus. But if we want to have an analgesic, an opioid analgesic during labor, it is preferred that we use pethidine because it causes less neonatal respiratory depression. The routes of administration of pethidine can be oral, intramuscular, subcutaneous, or intravenous. Next, we talk about the other synthetic opioids like fentanyl, remifentanil, and sufentanil. You have come across these drugs in the chapter on general anesthetics also. The advantages of these drugs are that they are very potent as compared to morphine in analgesia, nearly 80 to 100 times more potent than morphine. And very importantly, you have to remember that they are highly lipid soluble and fast acting. Being very highly lipid soluble, it enters brain very rapidly, and the peak analgesia is produced in 5 minutes after IV injection. The duration of action is short, that is 30 to 40 minutes. And another important thing is that it is producing less of CVS effects and less histamine release. So main use is in IV anesthesia, especially for cardiovascular surgeries, because it doesn't produce much of CVS effects. It can also be used in chronic pain like cancer or terminal illness as transdermal patch. From the beginning itself, you have always learned the example of transdermal patch as fentanyl, and now you're learning about fentanyl. And it is also used for postoperative and obstetric analgesia through the epidural route. So you can see that for the labor pain, we can either use pethidine or you can use synthetic derivatives like fentanyl, remifentanil, and sufentanil. And the point that it enters brain rapidly and produces peak analgesia in 5 minutes is already taught to you during the general anesthetic class, especially the IV anesthetics. That is why I'm not elaborated too much on that fact. But please remember, this is mainly used for IV anesthetics and as transdermal patch for chronic pain and for obstetric analgesia via the epidural route. Now, at this point, we can also discuss about Neuralept analgesia. This is a combination of droperidol, neuroleptic drug, which is again, you have not learned about neuroleptic drugs, which you will be learning in the further classes, and fentanyl. The rationale for use of this combination is mainly to provide sedation and intense analgesia without the loss of consciousness. So the person is drowsy when you give this combination, but he can respond to commands of the surgeon. The dose available is usually 0.05 milligram fentanyl plus 2.5 milligram droperidol per 5 ml, and it is used as IV injection. It is mainly used as short surgical procedures in poor risk patients, means in patients where you don't want to go give general anesthesia because you want to avoid the complications of general anesthesia. You can resort to this Neuralept analgesia, which provides adequate analgesia, and yet the patient is able to respond to commands because he is not fully unconscious. He is just drowsy and is able to respond to commands. So just remember what is Neuralept analgesia. Now, next we discuss about the methadone. Now, this is very important again. Methadone, you have to remember as a short note. If you remember, we already mentioned about methadone in the morphine class also under the de-addiction measures. The actions of methadone are very similar to morphine, but there are some distinctive features that you have to remember. It has got a high oral absorption and it is highly bound to the tissue proteins. In single doses, the methadone has similar duration of action to morphine, but it accumulates in the tissues on repeated administration because it has tendency to bind to the tissue proteins. As a result, the duration of action of the methadone progressively increases because it is very slowly released from the tissue proteins to which it is tightly bound. The plasma T half on chronic use becomes 24 to 36 hours. This point is very important that its duration of action increases on repeated administration because it tends to accumulate in the tissue proteins from which it is released very slowly. Now, because of the long duration of action, it is incapable of giving a kick. Kick is a pleasurable sensation which the IV drug addicts or the IV users of morphine get. That is not there with the use of methadone because of its long duration of action. Kick is always received with drugs which are having a short duration, very fast onset and a short duration. Then only you get a kick. But because it has got a long duration of action, this methadone is not able to give a pleasurable sensation in patients. Therefore, the abuse potential of methadone methadone is less when compared to morphine, because people are abusing it mainly for that pleasurable sensation. When the pleasurable sensation is not there, they will have less tendency to abuse it. Even the tolerance develops very slowly to the use of methadone. The withdrawal syndrome is there, but it is of gradual onset and it takes 1 to 2 days to develop after discontinuation. It is prolonged and less severe. Now, this is also very important that you know that when you stop morphine, the person gets intense withdrawal syndromes. I've already mentioned the symptoms that are associated with the withdrawal syndrome in the morphine, and it's quite intense. But in this case, when you take a person off methadone, person develops withdrawal symptoms, but it is quite slowly developing within 1 to 2 days, and it is quite prolonged. It is not very intense. It is something that the patient can get along with, or he can slowly get out of it. It is not as intense as that of morphine. So this is also these 4 points also you have to remember as the consequences of the long duration of action of methadone. Now, where are we using the methadone? Methadone is mainly used for opioid de-addiction in opioid dependent patient. So first therapy is substitution therapy. Here, 1 milligram of oral methadone can be substituted for 4 milligram of morphine, or 2 milligram of heroin, or 20 milligram of pethidine. So you can use it in patients who are addicted to morphine or heroin or pethidine. So this is the equivalent doses. Okay, suppose somebody is abusing 4 milligram of morphine, you have to replace it with 1 milligram of oral methadone. This given in 2 to 3 divided doses for 2 to 3 days and then stopped. The withdrawal symptoms will still appear, but they are mild and the patient can tolerate that withdrawal symptoms. This is called a substitution therapy. The next type of therapy for opioid dependence is opioid maintenance therapy, where sufficient dose of methadone, approximately 10 to 40 milligram per day, is given orally over long term. In the previous one, it was given only for 2 to 3 days and then stopped. Here, it is given for long term to produce some high degree of tolerance. Okay, you're giving it so long that there is some level of tolerance that the pleasurable effects of IV doses of morphine or heroin are not perceived and the subject gives up the habit. So here what you're doing is you're giving methadone and for a long time and in such a way that a cross tolerance develops to all the opioids. You also learned earlier that the opioids develop cross tolerance. So when you're giving methadone for a long time, it is then the patient takes heroin or morphine. There is a cross tolerance. That is, the patient will not be able to enjoy the pleasurable effects of morphine or pethidine, and he has to eventually give up the habit. And then you can slowly stop the methadone, similar to the previous way. And when you stop methadone, what will happen is that the patient will get withdrawal, but it is very mild and tolerable. Then methadone is also used for as an analgesic for the same conditions as that of morphine. So whenever you're talking about methadone, please remember that it is the main drug used for opioid dependence, and there are two strategies, either substitution therapy or maintenance therapy for opioid de-addiction. Next, we talk about tramadol and tapentadol. And these are considered as atypical opioid analgesic. This is because they have got multiple mechanisms of pain reduction. The first mechanism is that they relieve the pain by binding to the mu opioid receptors, just like morphine. The additional mechanisms are that they can inhibit the reuptake of noradrenaline and serotonin into the neurons, because of which what happens is that there is an accumulation of serotonin and noradrenaline in the synaptic cleft. They also release the serotonin, and thus they activate the monoaminergic spinal inhibition of pain. You have already seen in the beginning, I've shown you a slide where I've shown you the descending pathway, and I had shown you that there is a release of noradrenaline and serotonin, which is involved in the inhibition of pain. So by increasing the noradrenaline and serotonin in the synaptic cleft, the spinal inhibition of pain is activated. So this is also very important mechanism that is coming into play, and there is a reason why it is called as an atypical opioid analgesic, because it is not just the opioid mechanism but other mechanisms also which are contributing to its analgesic action. The advantage of tramadol or tapentadol over morphine is that the overall bioavailability of tramadol is very good, and it causes less respiratory depression, sedation, constipation, and urinary retention. It is better tolerated as compared to that of morphine. The ADRs which are reported usually are dizziness, nausea, sleepiness, dry mouth, sweating, and lowering of seizure threshold. So in patients who are known epileptics, and you should be very careful when you're giving tramadol because it can trigger seizures in such patients. The abuse potential is again very low with tramadol and tapentadol. It should not be given to patients taking SSRIs just like pethidine because there is a risk of serotonin syndrome. Now, where is this tramadol and tapentadol used? It is mainly used for mild to moderate pain, which is induced by diagnostic procedures, injury, surgery, etc. So you'll see a lot of tramadol and tapentadol being used in the surgery orthopedic wards, and it's also used for relieving chronic pain, but due to cancer, but it may not be that useful in severe pain. So next time you visit a surgical ward or an orthopedic ward, you please turn over the case sheets and you might find a random tramadol or tapentadol being given to patients. Now we discuss about the complex action opioids. Under this, we have got the kappa analgesics, that is pentazocine and butorphanol, and partial mu agonists, that is buprenorphine. This we will discuss under a tabular column. So first we have the pentazocine and butorphanol, and you can see it is a strong kappa agonist, and it produces spinal analgesia. But when you see the side effects, the sedation, respiratory depression, biliary spasm, constipation, vomiting are less severe than morphine because it is also having a weak antagonist action on the kappa receptor. That is the reason why these adverse effects are less than severe than morphine. Even the tolerance and dependence can occur on chronic use, but withdrawal is again milder with these drugs. Abuse liability is also less. However, it produces tachycardia and increases cardiac work, and therefore it has to be contraindicated in patients who are having who had MI because of this last point that it increases the cardiac work. So when you're using it for post-operative control of pain and chronic pain, you should make sure that the patient does not had never had a MI because in such patients it has to be contraindicated. Now, buprenorphine is a partial mu agonist. So I've already mentioned to you what a partial agonist is, that it is acting on the same receptor as a full agonist, but it produces submaximal effects. So you can see it is producing analgesia just like morphine, but it is slow onset and long duration, and it is less, it produces less analgesic effect as compared to morphine. Other adverse effects like respiratory depression is also comparatively less. The tolerance and dependence occurs, but the withdrawal is milder. Okay, and again, it is used for chronic pain. So these categories of drugs are used mainly for pain control, but as compared to morphine, they have got less side effects because they are either having some kind of weak antagonist action on the kappa receptors, or they are just partial mu agonists. So because of this, the adverse effects are mild or comparatively less in these drugs when you compare with morphine. Last, we will discuss about the pure opioid antagonist. And under this, you have example of naloxone. So it is a competitive antagonist on all types of opioid receptors, and it is given only by the IV route. So where is naloxone used? It is a drug of choice for morphine and other opioid poisoning, which we have already seen in the previous class. It is also given by the umbilical route in neonatal apnea because of opioid use, mainly the morphine use during labor. It is also used to reverse respiratory depression because due to intraoperative use of opioids. Now, this can also be used for diagnosis of opioid dependence in patients. So if you give naloxone in opioid dependent patient, it will precipitate withdrawal in dependent patients. So they will develop all the withdrawal symptoms which we have mentioned earlier. It also partially reverses alcohol intoxication. Then naltrexone and nalmefene, they are opioid antagonists, but they differ from naloxone in being orally active and having longer duration of action. They act for 1 to 2 days. So these are the pure opioid antagonists. So we have discussed the opioid agonists under natural, semi-synthetic, and synthetic categories. Then we had mixed action opioids, under which we have discussed under the tabular column. And finally, we discussed about the pure opioid antagonists, which include naloxone, naltrexone, and nalmefene. Thank you.